So continuing on with our series where we're considering anatomy and to at least some degree physiology, as well as considerations for osteopathic assessment and treatment, we're now making sure that our network of meaning or our semantic network is connected to movements more so than particular structures. So it's more about the movement than it is the structures. So it's the movement first and the related structures second, or those are the details that will allow you to start to pull things together. So the similarity of thoracic flexion to lumbar flexion as far as the structures involved in creating the motion will become apparent as we go through. So obviously we're looking at thoracic flexion here. Now our objectives here are to have a specific discussion of what thoracic flexion is with respect to planes and axes, general discussion of the bones of the thorax, general discussion of the muscles that flex the thorax, a general discussion of the nerves that supply the muscles of thoracic flexion, a general discussion of vascular supply, and then a general discussion of the areas to assess and treat should thoracic flexion issues be suspected or reported by the patient. Now, as we seem to do consistently, I'll probably touch on some of that as I go with respect to the areas to assess and address, or assess and treat rather, but there will be a specific wrap up of that at the end of the presentation. So looking at planes and axes for thoracic flexion, we've done this with other movements, but we will continue to do this so that it is a piece of information that is consistently returned to so that it becomes repetitive and that allows it to sink in better. And then it also puts it in the meaning network or the semantic network such that when you're thinking about movements in the cardinal planes, you're able to do this pretty quickly so that you've repeated it as information that's incoming, repeat it as information that you're thinking about, and then you will likely start to relate that to many things. So with respect to flexion, it is movement in the sagittal plane. So we just go over the planes really quickly. The sagittal plane is a 50% cut directly down the middle, cutting the body left and right. The horizontal plane is a cut that would cut the body in half, 50% top and bottom, and the frontal plane would cut the body in 50% front to back. So the sagittal plane being 50% left to right, the axes being perpendicular to it. So it is a sagittal plane with a horizontal axis or a transverse axis. People would speak about this or use both of those terms to describe the axis, but it is perpendicular. So you've got a cut here. This is the plane. The axis would be perpendicular to it. So because flexion is essentially a rotational movement about an axis, about a transverse axis in the sagittal plane, but if we use the term rotation to describe flexion and extension or side bending, then we have a harder time relating that to rotation. So rotation is primarily the term that's going to be used for motion in the horizontal plane or the transverse plane, but it is a rotatory movement about a transverse axis in a sagittal plane with respect to flexion. Again, translation would be movement, essentially translation across a plane. So it would be a straight line. There would be no axis, and that isn't necessarily something that occurs with normal human active movement in any of these planes. So flexion is forward bending or bending forwards of the torso or of the thoracic region in the sagittal plane about a transverse or horizontal axis. So it's forward bending. Now the thoracic skeleton, what you're looking at is the thoracic vertebrae, so 1 through 12. You are looking at ribs 1 through 12. Rib 1 attaches only to the first thoracic vertebrae. Ribs 2 through 10, generally speaking, in most specimens that have been examined, will connect, their demifacets will connect to the rib or the vertebrae that they're named for and the vertebrae below. So rib 2 will connect to rib 1 vertebrae 1, T1 and T2. Rib 3 will connect to T2 and T3, right? That's generally how it goes up until the point that you get to ribs 11 and 12. Rib 11 only attaches to T11, rib 12 only attaches to T12. It is entirely possible to have supernumerary ribs. So you could have somebody with a rib on C7. So that would be supernumerary rib on C7 or a cervical rib. That at that point you would have 13 ribs or 13 pairs. You could have a rib on L1. So that's supernumerary in the lumbar column, and that rib would be connected there. The supernumerary ribs on C1 would connect anteriorly. So they would go towards the manubrium. In the case of a lumbar rib, it would not connect anteriorly. So ribs 1 through 10 connect anteriorly. I believe it's ribs 1 through 6, essentially are directly to the sternum, or the manubrium in the case of 1 and a little bit of 2. Then what you get with 6 through 10, it is the common costal cartilage, which would come upwards to the sternum. And then ribs 11 and 12 have no anterior connection to bone. They have anterior connection to muscle, but they don't have an anterior connection to bone, at least. The, rib 1, rib 11 and rib 12 are considered atypical in that they only connect to one vertebrae. In the case of ribs 11 and 12, they have no anterior connection. So you will see some variation in how these are discussed, but that is your general concept for those ribs. And that is essentially a thoracic skeleton, aside from specifically noting the manubrium, right? So then the sternum, which when young is not necessarily a fused bone, it becomes fused over time. I don't remember the specific age where it's generally fused. And then you have the xiphoid process. So essentially you have sternbrae, they're called sternbrae. So the sternum would be multiple sections that have some mobility before fusion, but not a ton, essentially interplay between themselves. But what you get is fusion of that over time. So the manubrium is left over. Then you get the sternum essentially as a plate or as a united fused bone. Then you get the xiphoid process inferior to that. Those are essentially your basic thoracic skeletal bones. You can more or less extend this. You could have a discussion about the clavicles as part of the thoracic skeleton. You could have a discussion about the scapula as a thoracic skeletal feature. However, the scapula would probably belong a little bit more accurately to a discussion of the upper limb, because there is no bone-to-bone connection to the thorax. It is essentially slung by muscles. So you could have that discussion, or you could segregate it out with respect to your meaning network. And in the case of what we're doing here, I will segregate out the scapula to the upper limb as far as the related meaning discussion or the semantic network discussion. The muscles that flex the thorax essentially are your abdominal muscles. There really aren't any muscles that connect that are primarily related to the thoracic vertebrae that would flex it. So it's really torso flexion. So thoracic vertebral flexion is generated by torso flexion. So the torso essentially being everything between the neck and the pelvis, that is what flexes. Therefore, you get a related flexion of the thoracic vertebrae, because there's no muscles that really do it. There's no anterior muscles on the thoracic vertebrae that would make that movement occur. They wouldn't have particularly good pull. You have challenges with the organization of the thorax, the internal thorax or the mediastinum with respect to organs and what they have to do. So the lungs take up a bunch of space. You wouldn't necessarily get a bunch of good pull. So really thoracic flexion thoracic vertebral flexion relates much more to torso flexion. So the muscles that do that are your abdominal muscles. So we're going to leave out an abdominal muscle with respect to the function of flexion because of its actual function. So we'll go over that in just a second, but you have the rectus abdominis, which will basically attach from lower ribs, common costal cartilage, and through the linea alba, so the central tendon of the abdominal musculature down to the pubic symphysis, more or less, or the pubic arch, that will flex. You have the external abdominal oblique and the internal abdominal oblique. So the external abdominal oblique more so being attached to the lower 6 ribs on the anterior portion, having an oblique angle down towards the pelvis. So there is some connection to the iliac crest. However, the lower free border of the external oblique is the inguinal ligament. So it allows for orderly passage of structures posterior to it. So the femoral nerve, the femoral artery, the femoral vein, things of that nature, also some muscles. So orderly passage of the psoas tendon or the iliacus tendon or the iliopsoas tendon. Whereas the external oblique is more connected posteriorly, so to the thoracolumbar fascia, and then coming towards the iliac crest, as well as the linea alba. Now the transverse abdominis, because it is essentially perpendicular to the motion, so the muscle fibers run this way, its primary function is to more or less pressurize the abdominal cavity or kind of contain it. So it's like a belt, it'll cinch everything up. It won't necessarily generate motion in the sagittal plane. Fiber direction won't allow it to do so, whereas the rectus abdominis is like this. So you can see how if the attachment points came closer together, you'd pull forwards the external obliques and the internal obliques. What you would get with bilateral contraction is pulling essentially anterior. So it is really the abdominal muscles or the muscles of the anterior abdominal wall that will generate thoracic vertebral flexion by generating torsoflexion. As far as the nerves that are going to supply these muscles very broadly, it's going to be branches from the anterior primary rami of thoracic segments or thoracic nerves. So what they do in this cut that you can see, in this image that you can see, is it's going to come out and then run all the way around the ribs. So it's going to give innervation to the intercostal musculature, but then it's also giving innervation generally to the body wall. So the posterior or the dorsal primary rami are going to innervate sensory, a very narrow strip around the vertebral column, but motor, they're going to innervate the vertebral muscles, whereas the anterior primary rami are going to innervate the body wall. So the body wall, including the abdominal muscles. And because they have generally attachments in and around the ribs, it is the intercostal nerves that are going to come around, wrap around, and often descend downwards through the muscle that will provide both sensory and motor tone. And you can see how it runs through all those muscles. Even on the bottom portion of this image, you can see how it's going into the, more or less into the muscles, weaving in and even going anterior. So on the front where you see kind of like that, that's going to be the rectus abdominis. So you're seeing how it travels around and anterior, and it will also descend. What you're seeing here is the vascular supply. So the vascular supply to these muscles is at least somewhat related to intercostal circulation, not exclusively, it depends on which muscle you're talking about, but you're going to see that intercostal circulation traveling in between the ribs, in between intercostal muscles. So primarily, I believe it's between the internal and innermost, and to serve the area that it's going to serve as far as orderly exit, it's essentially at the top of the intercostal space. So, and I believe it's vein, artery, nerve. I may be incorrect about that, but then you'll get an artery and a vein at the bottom. And even here in a cartoonish way, you can see the intercostal nerve piercing through the muscles as far as supply is concerned. But some of it you're going to get from intercostal circulation to supply in some way the anterior abdominal wall, but not exclusively. What you're also going to get, depending on the particular muscle that you're talking about, rectus abdominis more so. So the intercostal circulation is going to go more so to the oblique muscles, whereas to the rectus abdominis, more so what you're going to get is branches off of the iliac circulation, right? So you're going to get some circulation from the inferior and superficial epigastric, and then from the superior epigastric. Now, the superior epigastric is off of the internal mammary. The internal mammary gives rise to the more or less to the anterior intercostal circulation. So that's going to anastomose with the posterior intercostal arteries, which will come directly from the the thoracic aorta. So you've got a pretty mixed circulation here. So some of it's coming off of the anterior circulation. So the internal mammary, which turns into the superior epigastric after it passes in through the diaphragm or in relation to the diaphragm, then to the anterior abdominal wall, providing some circulation there. And then you're going to get some coming up. So from the superficial epigastric and the inferior epigastric, and the superior and inferior will anastomose. So they essentially one artery, but their supply comes from different locations, or so from different branches off of the aorta or different locations. And then you will also have some, I believe some is going to come from the lumbar arteries, at least with respect, and I may be somewhat incorrect about this, but at least with respect to the internal oblique, if memory serves. So I may be a little bit wrong on that, but essentially your broad concept is that if the ribs are not moving appropriately, generally speaking, you can expect some circulatory challenges off of the intercostal circulation, which could be a little bit more likely to cause problems to the upper portion of the rectus abdominis. As far as the lower portion of the rectus abdominis, you would expect to find more of a challenge in and around the pelvic region or the low lumbar region if there is a pressure differential that makes it hard for the arteries. And then the pressure differential will be a little bit harder for the veins. So some of it's coming up from the pelvis and some of it's coming down from the thorax. regardless of which muscle that we're talking about, be it the rectus abdominis, the internal oblique, or the external oblique. As far as the drainage is concerned, or the venous side, for the most part, what you're going to get is circulation that's going to go back through the iliac veins. So from the lower portions, you're going to get it, so from the lower portions of these abdominal muscles, it'll go in through the iliac circulation and then up more or less through the inferior vena cava. But as far as the epigastric circulation, the epigastric or epigastric veins, some of that, and at least with respect to even the nerve and the nerve vasorum, you're going to get a bunch of this going through the azygous system. So the right side of the body is going to have the azygous vein itself. The left side on the top will have the accessory hemiazygous. The bottom will have the hemiazygous vein. So that kind of will communicate. So the abdominal wall will give some vasculature, or sorry, some venous blood back through that system, and some of it through the iliac circulation back up through the inferior vena cava. Now, as far as areas of consideration for assessment and treatment with respect to issues of thoracic flexion. So if you believe that, if you have reason to believe through findings or through report that there might be issues with thoracic flexion, the ribs and the T-spine, very, very broadly speaking. So if there is some form of restriction in excursion of the ribs, it could restrict the thoracic vertebrae in some way, shape, or form. So you would check all of that. You could check that simply through flexion and extension. So generally speaking, if you want to know if there's a flexion problem, you don't flex it, you extend it. So the test for problem with a specific motion is its opposite motion, right? If you are going to call it flexed, it must not be able to extend, right? So if you wanted to test for flexion, you would actually extend, and your proof would be that it did not extend. So you would check through the sagittal plane motion within the thoracic region, and then you would also want to make sure that the ribs were expanding and contracting, or inhalation and exhalation, so kind of changing their shape or changing their position accordingly and evenly side to side. Now, as far as concerns, things to stay away from, if you have any reason to know or suspect that there are fractures or tears, right? So a vertebral fracture, whether it's an SP fracture, a TVP fracture, some form of fracture in the body, maybe a spondylolisthesis, maybe somebody has spondylolysis, maybe they have something like very advanced Crohn's leading to ankylosing spondylitis, I believe, or that relate well. If you have any of those things, you want to be extremely careful. You would want to make sure that there were no tears, so no tears on the abdominal wall. You would want to make sure that there were no tears in the intercostal space, things of that nature. So you can, it's very rare that you'd have a tear in the intercostals, in the intercostal musculature, but it's at least somewhat possible. So you would have related to that recent trauma. But if there was recent trauma to the cage, and the person was having a hard time breathing, they couldn't take a deep breath, if they laughed, they were in a lot of pain, you want to be extremely careful there. That is essentially a contraindication or something to make you very, very, very cautious. So if that would be a place where patient active treatment may be more appropriate, because the patient can move to their comfort, and you're not going to put excess pressure beyond what is safe on something that could be fractured. Now, if there is a known or suspected thoracic aortic aneurysm, so an aneurysm on the thoracic aorta, you would want to be extremely careful, because if you increase the pressure or create large motion there, you may increase the pressure and then cause a vascular wall to rupture. Thoracic aneurysms are very difficult to detect for anybody who's doing hands-on therapy, because you can't see the telltale signs. So in an abdominal aortic aneurysm, even in people who are not as lean, you can often see a large bound in the abdominal wall, whereas with a thoracic aneurysm, you wouldn't see that. So that would usually be something that you would suspect as a result of medical imaging. So x-rays, well, not so much x-rays, but something such as a CAT scan or an MRI would probably show you that. But the person would have to have some symptoms to have called for an image. So some kind of circulatory issue, some kind of blood pressure issue where their physician would have called for the image, and then that would be reported to you. So very generally speaking, with respect to thoracic flexion or thoracic vertebral flexion, really what you're concerned with is the abdominal wall as far as actively generating the motion. But to treat the motion, generally what you're going to do is generate the opposite motion. So you're going to generate extension unless the person is in pain there. And at that point, what you would do is more or less go indirect. But if you're having a problem generating thoracic flexion, then the abdominal wall is concerned. If you're having a problem because they're staying flexed, again, you're going to consider the abdominal wall, and you're going to consider generating thoracic extension. But you want to stay away from, or you want to be very careful if you have reason to suspect fractures, tears, or aneurysms.